Well, since that created a pregnant silence, I might as well begin. So I'm Chuck Friedman. I'm the chair of the Department of Learning Health Sciences, which is a remissioned version of the former Department of Medical Education. I will be saying just a little bit about that change in my remarks later. But first, let me go over the agenda for today's town hall. We're going to begin with remarks by Dean Woolliscroft. After that, I will speak briefly and rapidly, but with some opportunity for you to ask questions. To introduce this concept of a learning health system, let me just poll the group here. How many of you have encountered this learning health system concept in your prior walk on the face of the earth? Okay, most but not, I'd say a little more than half of you. But we will have a primer on that concept. Then we are going to invite Rod Hayward and Bill Herman to offer their perspectives on why establishing what we're going to call learning cycles and a learning health system beginning in relation to diabetes care at this institution is an important and good thing to do. And following that, we're going to engage you in an interactive exercise. Those of you who RSVP'd to the invitation, and thank you for doing that, were asked to generate some ideas for care goals relating to diabetes care in the institution that might be addressed potentially by this learning process that I will describe in a moment. And many of you did, and we are going to present some of those ideas back to you and actually do a voting and priority exercise to close the town hall. And your priorities attached to these care goals will be a major and important outcome of this session. We also have a sheet of paper in front of each of you, the use of which I will explain in just a moment. But for the immediate present, we are very fortunate and pleased to have Dean Woolliscroft here, and we'll be honored to have his remarks to initiate today's event.
Thanks, Chuck, and I want to add my greetings and appreciation for all of you turning out this afternoon as well. I think, as indicated, most all of us have heard about learning health systems. There's been a lot of talk, a lot written about it. Victor Zhao and colleagues had a commentary in the New England Journal here relatively recently about the promise of learning health systems. There are examples across the nation of, if you will, startups, and there are examples of more mature, if you will, learning health systems. But Michigan, in many ways, is quite unique. As Chuck said, we consciously and intentionally repurposed the Department of Medical Education into the Department of Learning Health Sciences. To our knowledge, this is the first in the nation. Very importantly, not only is it a department within the medical school, but it has very close working relationships with the School of Information and the School of Public Health, and more broadly across campus. I'm very pleased that Chuck has been willing to take the responsibility of launching this repurposed department. It has the classic emphases in research as well as in education. Some of you may know that there's a plan to have a joint Ph.D. program among the three schools, which I think will be a very powerful educational program, also obviously continuing to feed the education and research mission of the department. However, the service mission is what we're really here to talk about tonight. Choosing where to start the whole journey towards a learning health system is no small task. And the choice has been made to focus on diabetes. There's a number of reasons for that. Clearly, just based upon the backgrounds of all who are in this room tonight, diabetes touches the institution, the university, the community in many, many different places. And so it is not an entity that is confined to one clinic, one department, one school. For that reason, it's very appropriate to look at diabetes generally as a starting place really for the learning health system. But beyond that, diabetes is incredibly complex, and there's a tremendous amount that we don't know about the entity. We don't know how best necessarily to even classify some patients along the whole continuum. And so really focusing on diabetes as a prototypic example for this initiative is very appropriate. I look forward to what's coming out of not only tonight's town hall meeting, but also, more importantly, the work that is done, not just to launch this, but to really move this whole initiative forward. So I appreciate your participation. I look forward to what will emanate from the discussions tonight and going forward, and am very appreciative that all of you are willing to engage on this journey together going forward. So thank you.
Thank you very much, Jim. We really appreciate these remarks. And let me now move into my presentation on the concept of a learning health system. So first and foremost, even though I am the department chair of the Department of Learning Health Sciences, this wasn't my idea. In fact, nobody knows who came up with the term learning health system. We're pretty sure that Al Gore did not do it, but that doesn't answer the question of who did do it. What we do know is that this term was socialized initially and continues to be socialized by the Institute of Medicine, which began talking about the learning health system around 2007 and subsequently has produced a long series of books and monographs on the topic. What is it, about 15, Josh? Such documents. And I place in front of you here two such documents. One a little more technical about the digital infrastructure for the learning health system, and another more recent which addresses how continuously learning healthcare, which we will talk about today, could be the pathway to best care at lower cost for this country. There have been several calls for the learning health system. Not only is this not my idea, I am certainly not the only one advocating the concept. The dean mentioned Victor Zhao's editorial that strongly advocated for academic health centers to lead the way in becoming learning health systems. And then in this editorial that appeared last year, Arnie Milstein argued that the learning health system is one of three steps that are absolutely necessary to safely limit healthcare's GDP footprint in this country, and I would recommend this article to you as well. So what is a health system that learns? What is a learning health system? I think you can boil down what is in a lot of books and monographs to 5 key points. In a learning health system, every patient's experience is available for study. So this can be done in many different ways. This can be done in a highly automated way. This can be done in a less automated, somewhat clunky way. But one key element is that every patient's experience is viewed as an opportunity to learn. A second characteristic of a learning health system is that for persons who are making decisions, whether these persons are care providers, whether these persons are care recipients, or whether these persons are administrators or managers of a care environment, the best practice knowledge that results from this learning process is available to them to support their decisions. In a learning health system, learning and improvement are continuous processes through ongoing study and analysis. Learning isn't bursty. When we detect a problem, we launch a study of it, and then we learn from that study and stop studying until we have another problem. That is not a learning health system. In a learning health system, the process is continuing and ongoing. Moreover, moving to the fourth bullet, in a learning health system, this is going on routinely and inexpensively, and I'll explain why it can be done relatively inexpensively in a moment. And after a while, like many things that become routine, they almost disappear. It becomes just the way we do things here. And it follows in the fifth bullet that if something is just the way we do things here, it is just part of our culture. So these are the 5 features of a system that learns, and in particular, a health system that learns. So if a system becomes a learning system, what does that make possible? Well, one, and perhaps first and foremost, given the theme of our town hall here today, is the pursuit of best and safer care at lower cost. In a learning health system, communities of interest that come together around specific problems discover what interventions work, what interventions are most cost effective, and are supported in making them part of routine practice. But that isn't the only benefit of a learning health system. Learning health systems can also support public health. For example, if we attain a national scale learning health system, we will be able to very efficiently track epidemics, and because we know where they are and we know where they were, we'll be able to predict where they're going, and that will have enormous benefits to public health. There's only one example of the ways public health can be enhanced by a learning system. And then there's a major consumer empowerment component to a learning health system, and it's very important that consumers be very much part of this story as well. In a mature learning health system, patients themselves will have access to the ability to learn from the system, and in particular, patients who are facing a difficult medical decision will be able to get a kind of information they can't get now. What happened to patients just like them who were recipients or who chose different care alternatives? And this can be extremely helpful, as you might imagine, to them in making their decisions. Many proponents of the learning health system envision it happening, envision it having a patients like me button, where it can be queried and consumers could actually ask, what happened to patients like me who did X or Y? So how does a learning health system work? It's fine to talk about these very important things that can be done if we achieve that state, but what is that state? What is it? How does a learning health system work? Well, a learning health system works through the implementation of what we call virtuous cycles of study, learning, and improvement. And those of you who have studied the organizational science have probably encountered this concept before. So if you begin at 6 o'clock on this cycle, you will see that a learning cycle begins with the decision by some community to take interest in a particular goal. And a goal of interest for purposes of a learning health system, looking up in the upper left of the slide, is typically one where, first of all, practices currently vary. Because if we all do the same thing, we can't possibly learn from naturally occurring variation. And where how to attain that goal is not clear. If we know what to do, if we know what best practice is and we know it unequivocally, that's not a situation where we have to learn because we already know. But if we have a goal of interest and a community forms around that goal, the process, once a decision is taken to establish a virtuous cycle to achieve that goal, begins at 7 o'clock with the assembly of data about what we do now and what the consequences are of what we do now, what the results are of what we do now. And then moving around, those data are analyzed. The results are interpreted, and here the cycle breaks. You can see a discontinuity here because here there is always an intervention where the results are interpreted, their significance is ascertained, and their credibility is ascertained. And a decision is made about what we have learned and what feedback to people in a position to make a decision should be delivered. Then at 2 o'clock on the cycle, customized feedback is delivered to the decision makers based on what you currently do now and based on what we learned. This is what you should do differently or what we believe you should do differently. And then some action is taken. That advice may be followed in full, that advice may be followed not at all, and that advice may be followed partially. And after that action is taken, there is new experience as a result of changed practice, and that feeds into the next cycle of this continuing virtuous cycle, leading in most cases to continuous learning and improvement. So a simple example, but I think an informative one, might be a community of interest forming around the unequivocally important goal of reducing falls in nursing homes. I purposely chose an example outside of the diabetes domain, but we will be talking about possible care goals in the diabetes domain in a little bit. So let's suppose a community of interest comes together to study and improve in this area. This could be a community of nursing homes all owned by one company. This could be a community of nursing homes in a state. This could be every nursing home in the country. It's a key feature of learning health systems and learning cycles is they work pretty much the same at any level of scale. So then the homes participating in this cycle would assemble data, and the data to be collected would be decided on by that community. That data would be analyzed, what practices are associated with lower fall rates. There would then be an interpretation. What did we learn? Are these results credible? And based on what we learned, what advice should we give? Feedback would then go back, in this case, to the nursing home, saying, based on what you told us you currently do, you might want to consider changing in the following way. Then action would be taken in whole, in part, or maybe in some cases not at all. And then that changed action, that changed behavior, and changed results would feed the next cycle, which would then begin. So many of you may be saying at this point, okay, well, we kind of do that now. And this has been something that has been around in organizational theory and in organizational practice across domains, not just in health, for many, many years. Well, here's what's different. What makes a learning process different from a learning health system is that in a learning health system, there is a platform underneath all of a number of learning cycles that are going on simultaneously, each addressing a different problem, each addressing a different goal. Some of them cycling more slowly because it will be in the nature of what is being addressed that some will cycle more slowly. But others, for example, in public health, in the case of an epidemic, cycling more rapidly because that's required in a public health situation or even a public health emergency. It is this platform that supports all of these virtuous cycles in any given environment that makes a learning system. If each of these cycles going on is a tub on its own bottom, doing its own thing, collecting its own data, doing its own analysis, working out its own rules, and obtaining its own permissions, then we have a lot of learning, but we don't have a learning system. So the key to where we eventually want to go, very importantly, needs to be understood as not only including a number of learning cycles or establishing a number of learning cycles going on, but also creating a platform that sits underneath all of them, supports all of them, and makes them efficient. When you have a platform under a set of learning cycles. The 10th one that you implement, the 10th cycle that you implement, will be only a fraction of the cost that it was to implement the first one. The economy of scale will be enormous. So we are talking here not only about cycles and the learning process, but just as importantly, we're talking about creating this platform. So almost to summarize here, the mature learning system, the environment that will exist, is many virtuous cycles each directed at a different care goal, going on concurrently, all supported by a shared platform. Studying continuous improvement, as I said earlier, would be a norm, and at any given point, the knowledge that has been generated by the cycle will be available to all the decision makers and all the stakeholders in that particular area. There are two anthems that have developed in the learning health system movement, to the extent that it's a movement across the country. One is derivative from what I said before, learn from every patient. And the second is one that goes to the pretty well-established latency between the generation of new biomedical knowledge and its routine use in practice. Some studies have shown that latency to be as much as 17 years. Well, with the learning health system, maybe we can reduce that latency from 17 years to 17 months by whole units of time, to 17 weeks, 17 days, or in a public health emergency, maybe even 17 hours, where that is necessary. So to bring my remarks to a close, in general, the plan we are envisioning here, and it's a plan that the dean's remarks portended, through, in part, the service mission of the new Department of Learning Health Sciences, but with the much more broad involvement of many people across the institution, is to establish a number of learning cycles, all supported by a common platform, but start in diabetes for all the good reasons that the dean mentioned. If we learn how to learn in diabetes, in addition to learning and improving care in this domain, we can begin to think about how to expand that platform and put it under virtuous cycles that will go on in other care domain areas. So one way to look at what we're here today is the official kickoff of the learning health system, initially starting in diabetes at UMHS. We also have a tremendous opportunity. We will do this anyway, but thanks to the Provost's Third Century Initiative project, we have an opportunity to apply very soon for Phase 2 funding in the Third Century Initiative, which could bring significant resources to bear in support of developing this platform to support a learning health system at UMHS, initially focused on diabetes, but as I said, eventually, if we are successful, and I'm sure we will be, expanding to other care domains. So today, what we are going to be doing is next hearing from Doctors Herman and Hayward. I will pause before we invite them to the front of the room to ask if you have any questions. And then, after that, we will be looking at some possible areas, some possible care goals, which might be the initial foci of communities of interest, and we're going to engage in an interactive exercise to prioritize those goals. So let me stop here and invite any questions that you might have, or perhaps some of my colleagues who are part of the cognoscenti might want to throw in some observations that are important, but I failed to make. And if you want to ask a question or make a comment, press the button, and that way everyone will be able to hear you.
We're also recording.
So Chuck, what's a platform?
Okay. So, thank you. This was not planned. I thought this concept of a platform might be a little bit abstract, so I was actually prepared for that question, but we did not rehearse this. But I'll pay you later. A platform is, as I said, that which underlies all these virtuous cycles and makes this an efficient system that can realize economy of scale. And I've likened a platform to a laundromat. I mean, if you think about it with a sort of simple but I think compelling analogy, let's suppose you had to do 20 loads of wash in one day. Well, you could, if you wanted to, you could find 20 of your neighbors who had washing machines. You could make arrangements to get into their house, find out what kind of detergent their washing machine uses, find out when they're going to be home, get keys, and go to each of their 20 houses, and I guess you'd get your wash done that way. Or you could go to a laundromat, which is persistent infrastructure, which has been developed for the sole purpose of solving that kind of problem. So you can think analogically of a platform as a laundromat, supporting, in this case, and moving out of my analogy, learning cycles in a learning health system. So what would a learning health system laundromat look like? What would it include? Well, it would include a lot of things that would be routinely available and ready to use for communities that wanted to come together and form these learning cycles around a problem of interest. So there would be mechanisms that help these communities of interest to form and help them kind of get organized and get going. There would be policies for getting access to data. In some cases, the data may be easily accessible. In other cases, there may be some challenges that have to be overcome to get the data. The platform would contain technology for aggregating and analyzing the data, and this is where the learning health system touches on the whole big data agenda for the institution. Some learning cycles are small data exercises, but others of them are big data exercises. The platform also includes technology and policy for making that feedback side of the learning health system work, for making that knowledge, first of all, persistent and available, and also deliverable as advice to individuals that have to make decisions. You don't want to build that each time you create a learning cycle, so you put mechanisms in place so that could be done routinely and easily. So these are some elements. I hope this answered your question. It's obviously 3 hours to do a full rendition of this, but this is the high-level depiction of what a platform might include. Yes, press your button, please.
So this is Eve Kerr from Internal Medicine. The description you gave is really intriguing, and I could see how we can learn a lot from it as both as a healthcare system and as an academic institution. But I did notice you didn't once mention the word research, and I just wanted to hear your view of how research fits with the philosophy of a learning healthcare system.
So it fits in a couple of ways. First of all, as I think everyone in this room knows, the boundary between continuous quality improvement and research is a very fuzzy one, and the processes one uses to do both of them are very similar. So I think it follows from that the platform that supports these virtuous cycles, and if you think about them as primarily quality improvement undertakings, can also support the same activities that probably, if you think about what is being addressed, are perhaps better described as research. So you change the problem, you change the thing at the middle of the virtuous cycle from a care goal of interest to a research question of interest, and suddenly this process becomes a research process supported by that same platform. So the platform really is, and thanks for asking that question, Eve, because the platform really is, in even a more transcendent sense, the tide that floats all ships, because not only can it support quality improvement oriented learning across a wide range of care goals of interest, it can also support research where the goal, what is depicted here as a goal of interest, becomes a research question. Yes?
Hi, Michelle Heisler from Internal Medicine. Related to trying to make concrete this idea of a platform. So if you think of a platform, is there also the idea that there'll be staff that are dedicated to supporting this? So it's kind of a support group as well as all the mechanisms that you described.
Yeah, great question. I think the platform, the components of a platform are technology, policy, and people. And I didn't mention people. And actually, one of the immediate benefits to us, if we can get this Third Century Initiative grant through the Provost's office, not only will we be able to build technology and catalyze the development of policy with it, we will be able to identify and support, at least initially, people who really are the things that make the whole process work. So thank you. I left that important people component out of my description of the platform. Yes?
Related to the people question, you talked about how patient engagement in the project was important to the missions and the goals of the project, but the way the patient engagement was described, it sounded more like in a passive way, pushing the information to them rather than actively engaging them in the process of development, design, and outcomes and the whole part of that. So I was hoping you would address more the vision of the patient's role in this project.
Mm-hmm. So great point. I thought I described the patient engagement scenario, the one example I gave, as a more active process, because if we have this patients like me button, it is the ultimate, to my way of thinking, patient empowerment tool, because it's very active. Patients can put their own queries to a learning health system and basically ask questions directly to the system that pertain to them and get and receive an answer. This is possible only in a fairly mature system, and more mature than what I've described at the moment. But my vision for this, and I think the vision that a lot of folks have for this, is patient empowerment in a very active way. In certain learning cycles like this, if the goal of interest is such that the feedback should come back to a patient, which sometimes is the case, then you could argue that in that scenario the patient is in a more passive role because the advice comes back to the patient. But even then, if you go to the take action component of it, they will do what they think is best with that advice, and it's in their hands to take the action or not that is recommended. So if I implied that patients are passive participants in this system, it wasn't something I meant to imply.
I'm sorry. Just to follow up on that, I think there's a distinct difference between this helping patients versus patients providing input that providers then have to respond to, and patients and consumers almost demanding changes and better care outcomes from the system. And so in particular, work with individuals traditionally underserved, health disparities groups, saying we need more, we need service provided in a different way, ways that are more tailored to us, our strengths, our needs, and asking the health system to respond. I believe that's, sorry.
Okay, point very well taken. Do we have time for one more question, or do we have to declare that the last question?
One more.
All right, if there's one more question, my embassy says there's time for one more question. Okay, hearing none, thank you. Those were great questions and were, I think, very, very useful to clarify and expand on some of the points that I made. So let me ask Drs. Hayward and Herman to come to the front, and I don't remember who we decided was going to speak first. I think, Rod, you were going to speak. You were going to speak first.
I decided not to compete with Bill in terms of dress. Just wouldn't work for me. I think I was invited because in an informal conversation with Chuck that I was a little bit of a rabble-rouser. I think this is a great idea. I think it's a critical idea. But I tell you, I have, as a researcher interested in quality improvement, in increasing public and consumer input and things, I have worked extensively with Kaiser Permanente, extensively with the VA across the nation, and have virtually never worked at U of M, even though that's where I provide my care. And it's a cultural thing. Confidence is good. We tend to recruit really good clinicians, really good staff and leaders, but the fastest path to mediocrity is thinking you're so good that you can't improve. That thinking that we are naturally so endowed with an ability to figure out what is best that empiricism drops away. It's just whatever we think is the best. We propose that we're science-based. We're supposed that we're patient-centered. Those are things that need constant loops for feedback. You don't get that in normal life. And it's been well shown in any industry that if you don't have that loop, you will not do as well. This is not a magic system. It is what the culture, the intelligence, the problem solving, and the devotion to our missions makes of it. We are also entering a new world where we can do things that are so much greater than what we could have done before. And ways that will actually make each of our lives as clinicians easier as well, but even more important, make our patients' lives better. Two quick examples. One is, my chart has had a not off to a rocket start, and there was some bumps in the road. But how fast we have loops that feed back to it, and a commitment to make those change determines what it can achieve. It has a lot of power. It's not the electronic medical record's fault. It allows redesign. It is how much we are willing to devote a little extra effort to provide that input, and the will to be reasonable and to keep those missions clear. I don't think I'm the only one who gets a large number of alerts every time I try to prescribe a medication. Anybody else that's a clinician here who gets a lot of alerts? I have never changed my prescription based upon any of those alerts yet. Someday I might, but I haven't yet for something that takes a lot of extra time every visit. When you have huge numbers of false positive, human engineering shows that people do one of three things and they're all bad, right? They take the time to read every alert carefully, so you've wasted time when we don't have enough time with our patients as already, right? You ignore them. That means when a real alert comes along, that you don't get that message, Betsy Lehman, the famous case about needing systems that got 10 times the chemotherapeutic dose, was a result of alerts that went off all the time that people ignored it, right? And the third approach is you turn off the system altogether, right? We can have feedbacks and really improve that system. The system is what we make of it. Another thing is we often have guidelines that treat all diabetics the same. Diabetes, cardiovascular equivalent. When the glucose is this, you should have some sort of intervention to prevent diabetes. We know that our systems and different decision rules can distinguish those people that have a very high risk of developing diabetes, a very high risk of complications, and very low. We do not do our patients a service when we treat just as intensively in the people at low risk and very high risk. We're either over-treating or under-treating. It has also been shown that you can never do as well using Framingham or UKPDS than learning from your own system. There are ways to make it easier for clinicians to document and do the right things. These require commitment. And I think it's a time that we come together. And the diabetes community is probably a small enough community here for us to pull together and really be dedicated. The biggest pitfall is people being too worried about things that will make their individual life better and not enough on prioritizing the things that are our missions. And our primary missions are excellence in patient care, excellence in scholarship, and excellence in leadership in healthcare, both in our state and nationally. And this provides that opportunity. But we will determine the people in the room, not the designs here. The designs here give us a roadmap. We can easily drive off a cliff if people are not thinking about those missions. So I'm excited about this new approach. It involves all the things people have asked. How much it'll include patient wishes and involvement is up to us, not the system. How much we will do more, target the big important things and improve, how much we'll learn is up to us. And I think we're ready for that challenge. So I look forward to it.
Like Rod, I'm delighted we've taken on diabetes as the initial focus of the learning health system. If we can get diabetes right, I really think we can take on any disease here at the University of Michigan. Diabetes is common. It affects 1 in 10 people in Michigan, and it's expensive. It accounts for 1 in 5 healthcare dollars in the United States. It's also heterogeneous, as the dean pointed out. There are people at risk for diabetes. There are people with undiagnosed diabetes within our health system. There are people with type 2 diabetes. There are people with type 1 diabetes. Diabetes is also both a primary care and a subspecialty condition, and I think in that sense it really challenges us. Optimal treatment involves the coordinated efforts of nurses, dietitians, educators, social workers, primary care physicians, pediatricians, endocrinologists, ophthalmologists, pulmonologists, gastroenterologists, nephrologists, neurologists, podiatrists, cardiologists, psychiatrists, obstetricians, and surgeons. Did I miss anyone in the audience? Hospitalists, absolutely. Thank you. So diabetes, I think, because of this, really challenges us as to how we schedule and see patients, how we divide responsibilities, and how we talk and communicate with one another. Diabetes is also different in that it's an acute illness requiring reactive care for things like hyperglycemia, hypoglycemia, and infections. And at the same time, it's a chronic illness requiring proactive care for things like blood pressure, lipid management, immunizations, eye, and foot care. Optimal treatment of diabetes involves outreach, tracking, and monitoring our patients, as well as behavioral, pharmacologic, and even surgical interventions. As the dean pointed out, the evidence base for some treatments is strong, and for others, it's remarkably weak. And we are faced with wave after wave of new and expensive drugs and technologies without clear evidence as to who can benefit most and under what conditions. In all aspects of care, we must weigh patient preferences as well as the potential benefits and risks of the available treatments. In addition, diabetes care is in the public eye. It has been and continues to be the focus of professional societies, guidelines. Employers are concerned about diabetes, as are payers and quality improvement organizations such as HEDIS. So I think we as a health system have the ideas, the tools, and the will to take on diabetes. As always, I think the devil will be in the details. Thanks.
So, thank you, Rod and Bill, for those terrific remarks, and I think they are a great transition to the next and what appears to be final piece of our town hall here today, but actually in the blank on the bottom of the slide, there is something near and dear to my heart, and that is food. And we are inviting everyone to a short reception immediately following the adjournment of this session, and that will be where? In the very back. Okay, so it's right in this room, and I'm very sorry I failed to mention that, but I'm glad I remembered to mention it to you now. So let me now invite Doreen Markle, the director of the Brehm Center and holder of many other important roles in the institution, including a very active participant in the beginnings of this learning system for diabetes activity, to the podium now, and Doreen will lead us in our prioritization exercise. Doreen, thank you.
Thanks, Jeff. I have to start your slides from now. Let me just get this the right way. Okay, now we get to do the fun part, which is where we get to, in a technological way, hear from all of you. So what we're going to do, as Chuck mentioned earlier, is take all of the input that we got from those of you who RSVP'd early enough where we were able to then send you a short survey asking for what your highest priority goals for diabetes utilization of a learning health system would be here at the University of Michigan. So when we got all those in, and thank you to all of you who responded, and some of those who responded, your responses came in too late for us to incorporate it into this process, but we definitely have held on to every single comment that you have shared with us, and we're also going to consider those in anything we get at the end of the session today as well. There was a small committee that was put together to review the input that we've got from those of you that sent in your comments. And what we tried to do was, now that you've had a small tutorial on what a learning health system is, we tried to condense down and group appropriately those goal suggestions that are most compatible with the idea of continuous cycle of a learning cycle. From that, we selected 8, and what we're going to do is walk through those 8 with you, and we're going to do a voting process. You've all been also distributed those slips of paper that Chuck referred to. So if after you see the 8, there is an idea that you do not see on the screen, please make note of it, and we're going to collect those from you at the end of the session today. So as 2 of our attendees mentioned, and I was ready to sort of interrupt while Chuck was answering about the need for patient and family-centered care. This is personally a really, really important philosophy to me. I was a member of the Ideal Patient Care Experience Task Force here for many years, worked on getting that to be one of the strategic aims of our health system. So even though you're not going to see patient and family-centered approach as a goal, I want everyone in the room to understand that it's an overarching philosophy of how we're going to approach every single one of the goals that you'll see up here. So it's an implied, we actually had a statement at the beginning, but we took it off because of size. So I just want to echo the two folks in the audience who already brought the importance of that to our attention. As we go through these, I have two colleagues from the Department of Learning Health System who are here that were working on the team that sorted through all the comments that came in. So Gretchen Pyatt. Gretchen, you want to stand up? And Marty Fennell. If you have questions, they work extensively in the field of diabetes education and research, and they will try to help answer questions that you may have about what we mean by any one of the goals that we're going to put up. I think Kathleen is still working on that. So the other rule is when you see all 8 up there, we're going to read through them one by one, and then we're going to go back and ask you to vote on each one at a time. You are allowed 3 yes votes. Yes meaning that this is a goal that you think is of high priority that we should consider to take on as one of the early goals of a learning health system diabetes initiative. The ones that are not in your top 3, when we get to that, vote no for those. So rather than ranking or whatever, you just have to pick what your top 3 are. You don't have to rank them within the top 3. Just vote yes for those and no for the rest. And then by that process, when we're all done, we will have an idea of what are the highest 3 ranking goals from this group in the audience. Larry? How many clickers do you get? You get 1, Larry. So these are the top 8 goals that we received, either some variation of it, or there may have been more than one of you that sent something similar in that we sort of blended or generalized in some way. Let's go through them one by one. So number 1, optimizing care to more specifically target reduction in A1C levels as opposed to hitting a fixed target A1C level. Most people have a good understanding of what we're trying to project with that one? Okay, number 2, integrating all healthcare professionals into diabetes care across the healthcare system. You can see how number 1 and number 2 are very, very different size and scope type problems, and these are also to give you an idea of just the broad dimension of different problems that can be addressed by a learning health system. Number 3, optimizing models and approaches to diabetes care for specific diabetes subpopulations. By subpopulations, geriatric, pediatric, get the idea? Number 4, improving participation in and outcomes of programs for effective obesity management amongst diabetic patients. Number 5, managing across the health system multiple comorbidities in patients with diabetes. Number 6, managing multiple diabetes complications across the health system. Number 7, identifying and addressing socioeconomic and psychosocial issues that interfere with diabetes care and self-management. And number 8, improving care and outcomes through active patient engagement. So I'll give you all a few moments to sort of study those and in your minds decide what you think the top 3 are. Managing across the health system multiple comorbidities. Okay, comorbidity. We had actually a conversation about the difference between comorbidities and complications. Marty or Gretchen, do you want to try tackling that?
I think you're right. It can be a little fuzzy, but I think we were thinking specifically in the complications of things like nephropathy, neuropathy, as opposed to hypertension. Something that's sort of related but not specific. Specifically a result of diabetes.
So you're talking about comorbid complications as opposed to comorbidity with depression.
Yes, exactly.
So I'm going to just say this now rather than wait to the end because I don't want to forget to mention it. What we hope to do once we've identified sort of the top priorities from the group and then also looked at any other priorities that you give us on the forms today is we want to form communities of interest around each of these potential goals. Communities of interest are anyone, and it's going to include patients and providers and educators, people who are really interested in wanting to see that goal as something we adopt in the learning health system as one of the early initiatives. Again, this doesn't mean that only the few things that we select now are going to be the only things, but we've got to start somewhere. And identifying some of these goals is just our starting point. So please take those forms seriously. Put your name at the bottom and your email address so that we can contact you. If we call you and you're not interested in engagement, there's not going to be any obligation, but this is a grassroots effort. The problem that we want to solve has to be a problem that's important to all of you, or what's the point? So we really need engagement of those who are going to benefit from the problem in the entire process. Larry? Press your button.
Can you speak to the overlap or connection between items 7 and 8, then potentially back to 4, from a 7-8 cluster to 4? Are there connections there or not?
Well, all of these are fairly vague right now and will have to get fleshed out in more detail. Again, these are just a starting point. So there are connections all over the place. None of these are going to be, if you do one, you somehow are going to spill over and have implications for the others. So I wouldn't be worried too much about this because the community of interest that forms around these will really tease apart what do we really want to do, how do we want to do it, what data do we have, what data do we need, who do we need at the table to, there's a lot more work that has to go in. Any other questions for Chuck that you didn't get a chance to answer earlier while we have a pause? Or for Rod or Bill? Yes.
You had mentioned the people, and with the feedback loop, the idea of combining the patient or the empowerment as well as the people, so not just collecting data, but doing something with it, both informing the decision makers and hopefully or possibly changing the system. Are there then going to be those part of the people, the educators on the ground, to help with changing the learning process?
Thank you. That's another great question. Larry Ahn is in the back of the room, and I may also ask him to comment because this is near and dear to his heart. But we are not assuming that the feedback will automatically trigger the change from now at 3 o'clock in the virtuous cycle. So there's a whole process there that cannot be taken for granted. And tailoring the message to the recipient is only a piece of that. And there may be, as you are suggesting, the need for human intermediaries in the change process to help ensure that the changes that one believes be changed for the better actually occur. So that's a very important point, and in this 40,000 foot view of the learning cycle, we didn't include that level of detail, but that is not a level of detail that can be skipped over or taken for granted. Larry, do you want to elaborate on that?
Can I just say yes? Yes. Should we just absolutely, and we'll have more conversations. I think that there's pooled expertise both in the room and across the university and the country to help address those issues.
Okay, we're going to do the good old raising your hand. So what we're going to do is, again, even though you don't have the clicker, you only get to raise your hand 3 times. We're going to put the slide back up. And I ask, where's Molly? Yeah, I need folks. Molly, you're going to count There's like nobody right down the middle. You're going to count everybody on that side of the room. And Kath. Oh, okay, we do 3 sections. Josh, you do that section. Molly, the middle section. And Kathleen, can you do the side section here? And then I'll write down the numbers. Thank you. Okay. Raise your hand if you believe that number 1, which is optimizing care to a more specifically target reduction in A1C levels as opposed to hitting a fixed target A1C value, should be one of the top 3 priorities. Raise your hand if you want that in the top 3. Okay, 0 from this section. 7. 0. 7. We don't need to do the no's, I don't think. Number 2, integrating all healthcare professionals into diabetes care across the healthcare system. Raise your hand if that's a number 1, 2, or 3 priority for you. $17. Josh, your section? Well, how many?
472.
Okay. Number 3.
We're really high-tech here, folks.
We can even add. Optimizing models and approaches to diabetes care for specific diabetes subpopulations. If that's in your top 3, raise your hand. Three. 1 is 4.
How many in the middle?
That's 18. Yep, got it. Yeah. Okay. Number 4, improving participation in and outcomes of programs for effective obesity management among diabetic patients. How many, Molly? 3? 2? 5? Number 5, managing across the health system multiple comorbidities in patients with diabetes. And again, comorbidities, not complications. 0, 0. Number 6, managing multiple diabetes complications across the health system.
Oh, I'm sorry. Sleep at the switch here.
Keep your hands up, please. 5? 9? Okay, number 7, identifying and addressing socioeconomic and psychosocial issues that interfere with diabetes care and self-management. Three, 2 is 5. 15? So 18?
20.
Okay, number 8, improving care and outcomes through active patient engagement. Whoa, everybody. I have to wait for. Okay, 22? 26? Okay, here are the results. So the outcome for the first one is 7. Number 2 is 22. Number 3 is 19. Number 4 is 5. Number 5 is 7. Number 6 is 9. Number 7 is 20. And number 8 is 26. Can I ask my counters to also count the total number of people in each of your sections so we know what the N is? 65? Is there 65 still in the room voting? Okay, well, close enough probably for this. Okay, so the top 3 priorities are number 8, number 2, and number 7. So I think we've heard a very strong voice about the improving care by active patient engagement. And again, that's a very, very, very broad topic that can mean many, many things. Number 2, integrating all healthcare professionals into the diabetes care across the healthcare system.
Doreen?
Yeah.
The statistician in me suggests that 3 is so close that we really ought to,
Okay.
and there's a nice break between
Yep, there is.
those 4 and the rest. Maybe
So-
we should identify those 4
That's a-
as those that have been identified.
Good idea. So we'll add number 3, which had 19 votes, which is very, very close to number 7 that had 20. Optimizing models and approaches to diabetes care for specific diabetes subpopulations. Do we have any time for any feedback from the group about any of this?
Well, I think, Jen wants to make a comment.
Yeah, they're all really important. And that's why I said, as Chuck described in his comments, this is just to get something started. And then once you have this in place, hopefully we can take all of these on over time.
So let me make a suggestion.
Yeah. Running late on.
Yes, and we're running to the end of our time, but I would like to make a suggestion on your sheet of paper. First of all, suggest any care goals that are not included in the 8 here that you would like to see in the queue for consideration down the road. The other thing we'd like you to do is indicate those problems, those care goals, ideally 2, 3, 7, and 8, that you, now I'm looking at the form.
Yeah.
Helps. Well, I probably should just tell you to complete the form, but we are particularly interested in where is there specific care goals in mind? Are there goals in your? Didn't we want to ask them to say which ones they would participate in?
Is that on there, Kathleen?
I believe that's the last one. That's great.
This form came together at the late hour yesterday, so Chuck
Okay.
didn't have a chance to see it
Right, so where is that?
at the very end. Very last one.
If so, then you would like to be involved in it?
Yeah.
Okay, so down on the very bottom, what we particularly would like to know, with emphasis on the 4 that receive the highest number of votes, but if you want to include any of the others, that's fine. Which ones are of sufficient interest to you that you would like to, or be willing to, or be interested in being part of a community of interest to move a learning cycle around that care goal forward? As I think Doreen said earlier, you are not making an irrevocable commitment here. This is a grassroots effort, and it is fueled by a spirit of volunteerism and interest and commitment. So this will be the start of a process that evolves as we move these communities of interest forward. But we would like to know which ones of these you would be interested in participating in.
The other comment I want to make when you're generating your own additional ideas, don't be worried about whether or not you think your question is a good fit for a learning health system or not. So many of the comments that came in when we surveyed those who RSVP'd were, they were really, really broad, but some of them allowed us to sort of pinpoint something down that we hadn't thought of before. So put it down there. Don't worry about if it's learning health system or not. We can probably learn from whatever you tell us. Kathleen, how are we with the caterer? It's ready.
Okay.
So, but you can't get up until we have a form from you. So is it just behind the doors?
Okay, behind door number 1 is the food. All we need is Monty Hall.
Thank you, everyone, for your participation. We know it's a beautiful day out there and that you are spending it in this room with no windows. And happy Rosh Hashanah to any of our Jewish colleagues who are delaying their celebrations this evening.
Okay, thank you, everyone.